So you want me to share my slides, right?
Saibal? Yep,
Yes.
Saibal, thank you, Dr. Mukpade. We'll look forward to discussing with you in about right after Saibal's talk.
Thank you. Thank you. Yeah.
Saibal?
Yep, I'm ready.
Yep,
Can you
it's all on you.
Sorry. So my topic is, I'm sorry for being delayed because of my computer issues. Transcatheter mitral valve replacement, the present scenario and new developments. And I'm following a talk on TEER and TEER, which is actually relevant. So I'll start by saying that transcatheter edge-to-edge repair is suitable for high surgical risk patients with primary MR and secondary mitral regurgitation, as shown by Dr. Sai, irrespective of the surgical risk. Transcatheter mitral valve replacement could be useful for patients who are not suitable for repair and are high risk for surgical replacement. The Tendyne valve is the only CE mark approved device, and all the rest are investigational. The role of TMVR relative to TEER needs to be well defined through clinical trials. So when you look at TMVR, we can say, what is the promise? The promise, it could be one-shot therapy. It could be agnostic of the pathology. There could be complete MR elimination, and it could have the ability to treat mitral annular calcification, which are difficult to treat otherwise. But what is the reality? The reality is there's no FDA-approved device. All are investigational in the US. There's one CE-approved transapical device. The approach is thoracotomy or a transapical delivery, or if it's transfemoral and transeptal, we have a very early experience with very large bore sheets, almost 40 French. These valves require anticoagulation long-term, 6 months at least, maybe 1 year, and there are significant anatomical exclusions, such as annular size, LVOT obstruction, and of course, the size of the ventricle and the ejection fraction. And finally, if you suddenly reduce mitral regurgitation in a patient who's got LV dysfunction, it may result in afterload mismatch. So what are the devices that are available or in trials? On the left side is the transapical systems, which where we go through a small incision of the apex. So in reality, the only one that is viable now is the Tendyne. In the transeptal systems, I can show you at least 6 or 7, there are even more. More important is the Intrepid valve, which was shown in the transapical side, is now on the right side as a transeptal system. The green line bar involves the only device that is CE mark approved, and the red boxes represent the devices which are in pivotal trials in the US. The rest are just early feasibility. So I'll start with the transapical Tendyne valve, which has got the most data, which you can see is a unique valve with double layers. It's repositionable, it's retrievable, and it's done through the apex with a pad. And the design is tri-leaflet with an outer frame that contours to the annulus and the inner valve, which is circular. A small transapical incision is done, and then a large bore sheath is advanced. The valve is deployed on the atrial side and pulled against the annulus. And then once it's pulled and it reduces paravalvular leak, the valve can be pulled and then the tethers are removed. And there's a long tether which is attached to the apex, and there's a pad. The nice thing about this valve is that if you don't like it, you can actually completely recapture this valve and take it out. This is an example of one of my patients, actually my second. She had an 82-year-old lady who had a mixed mitral valve pathology of mild rheumatic with functional MR. And he had shown a very severe broad jet, and she was in heart failure when she presented to me. She underwent a transapical, and you can see here, the first part of the procedure is doing a transapical incision, advancing a wire to the LV into the left atrium, and then gradually making a balloon, making sure that we don't attach any cords. Once we know we're free of attaching the cords, we advance the large bore sheath and then the valve in the atrium, and you can see the valve is being deployed. It looks like a large cage. And this is what it looks like transcendental echo from the atrial side. And that is what it looks like in the two-chamber TE views, showing that there's no perivalvular leak, a very nice shelf, and you can see the taper of the valve with it attached to the tether. This is their data that's over 1,500 patients who were treated worldwide, which has the largest experience, and there's a randomized trial in the United States ongoing. The next valve is the Intrepid valve, and this valve is now owned by Medtronic. And you can see over here, it's a circular inner valve with a 27 trilid bovine valve, and there's an outer circular frame, and this frame actually anchors to the annulus as well as to the leaflets to these little anchor points. There are two sizes, 42, 48, and there's a 54 in development. So this side valve has to be oversized in order to actually be positioned safely. So if you're dealing with a 40 annulus, you've got to use a 48 valve. Now this valve is now become a transit, was originally transapical, but is now a transeptal delivery. Now let's go through a few examples of transeptal mitral valve replacements. Now the first one is the Edwards valve, and what it is that they create a docking station in the subannular space, and then you just deploy a transeptal mitral valve, which is just a sapien valve, but covered with foam to actually make it occlusive. So you can see over here, you do a transeptal puncture. It's an 18 French system. You advance a curved catheter out. This curved catheter then you can see is being placed at the medial commissure. And once you're in the medial commissure, you advance a ring. And this is the part which takes the longest time, is to encircle these rings around the leaflets and the cords. And then once you've managed to do that, you release the top part of the ring, which anchors it below and above the annulus. And then once you've created this platform, then you do a standard transeptal system, advance a wire in the LV, and deploy the sapien valve. And you can see just over here, we're just going forward, and this is something which people can do very easily. So the second part of the procedure is quite easy. This is the 18 French delivery. The next one is the High Life. The High Life is a valve where it's a two-part system similar to what I just showed you. But in this case, the ring is formed through an aortic process. So you go with an 18 French catheter, transaortic, you create a ring by putting a wire around the cords, and then you create a ring, which is the middle. And then once you create that, you do a transeptal valve, just similar to what we just did before. So this is one of my first cases. This is actually a patient who underwent a Clarity, but watch the valve in the beginning. You can see that it's not completely occlusive with fabric. It's open cells. So you can see this is severe mitral eccentric MR, and then we put a valve inside. This is 3 months later. You can see there's no perivalvular leak and no mitral stenosis with a mean gradient of 5. The next is the Intrepid. You saw the valve before, but the Intrepid valve is now can be delivered transeptally, and it's a very complex delivery system. And the sheath size is 35 French, but it actually becomes external diameter is 40 French. So you have to actually do a cut down in the vein to advance the system across the septum. The Cephea valve is now owned by Abbott. And what it is, it's a double disc valve. So you have a ventricular disc, an atrial disc, and then you have a valve in between. And the beauty of this system is that the delivery is very similar to the MitraClip. So it's the delivery system can be navigated appropriately. You deliver the ventricular disc. Then once you're again, you deliver the atrial disc, similar to like an Amplatzer ASD device, and the valve is inside this. I find this actually and this is a very short valve. You can see the frame is very short, and you have 2 discs, one lower disc and one upper disc, and you have now 2 sizes. So this is an early feasibility trial in the US. Now going back to just clinical trials and a few words on data, the one that is ongoing is the Summit trial, which is a randomized trial comparing MitraClip to TMVR and the randomized cohort or in those with mitral annular calcification, or where the valve is not repairable, it's a single arm study. So you have two studies, the tear suitable arm and the non-tear suitable. The non-tear can get the device. As expected, the randomized arm is obviously going very slow, but the MAC arm, the mitral annular calcification arm, which is a true unmet need, actually the enrollment is completed and there's a continuous access. So last year, we already finished 103 patients. Now, the other trial is the Intrepid study with the Intrepid valve, which is also called the Apollo trial. And in Apollo, you have two parts, the primary cohort and the MAC cohort. In this one, the FDA allowed them to choose patients as a single arm study in patients where the multidisciplinary team didn't think the patient was good for TR or for replacement. There's also a mitral annular cohort, which is ongoing. And then finally, they hope that once they get data from these two sub-studies, they will potentially do a trial against transcatheter edge-to-edge repair. Now, if you look at the outcomes of all the systems, I want you to summarize some of them. There are various valves. And what is concerning is, look at the 30-day mortality. If you look at the 30-day mortality of these transcatheter mitral replacements, they are significantly higher compared to transcatheter edge-to-edge repair. And so this is a concern. Even though the MR severity is traced to none in most cases, there is a procedural risk. The benefit, of course, is MR elimination. The risk of TMVR versus the benefit of MR elimination must be therefore studied in clinical trials. Now, this is just the 2-year outcome of the 10-9 valve. And what you can see in this group, of course, remember, this group was their early experience and they had taken patients which were not great. You can see the MR reduction was fantastic. But when you look at the mortality at 2 years, it was 41%. So there's a question about the long-term safety of these valves. So we need to summarize TMVR versus TR. You can see that TMVR leads to complete and sustained reduction of MR. But the devices are investigational. They are definitely more invasive. And there's a need for long-term anticoagulation, which is a big deal, especially in older patients. Transcatheter edge-to-edge repair, on the other hand, is a transfemoral, demonstrates safety and efficacy, FDA approved, and there's a higher potential of residual MR. So here is no MR versus 2+ MR. And this is where we compare these two major forms of therapy. So the challenges of TMVR are actually real. Access site complication, apex of the heart or the femoral vein. 60% of patients get excluded because of LVOT obstruction risk or size of the annulus. There's always a risk of valve thrombosis because of the bulky devices. There's a long-term risk of bleeding because they need Coumadin. There's a risk of infection because there's a prosthetic valve and may not be tolerated in patients with severe LV dysfunction. Notwithstanding this, I would actually like to make a conclusion that TEER is a well-established therapy that can successfully treat a wide spectrum of MR pathologies. TMVR has the promise of complete MR elimination, but there are anatomical, but those are ideally for patients with anatomical limitations for TEER. TMVR is more invasive than TEER, and the risk-benefit ratio must be proven in clinical trials. Transfemoral and transapical systems exist, each with their advantages and disadvantages. And I'd like to thank you very much, and the session is open for questions.